Good evening, everybody. Thank you for taking the time to join me and everybody on the Propel team to talk about how we can use micro-osteoperforations to grow your practice. I'm sure that every single one of us all feel the same way about our cases, and that's how we can get our cases finished as fast as we possibly can. And fortunately, all of our patients feel exactly the same way. And so I think that in today's day and age, everybody wants everything as quickly as they possibly can, and they don't really want to wait for it. And I think that this is where Accelerated Orthodontics really comes into play, because now you actually have something to offer the patients. In the past, the patients would come into my practice and they would say, "Doctor, I want to get my teeth straight, but I don't want it to hurt. Please don't make it hurt, Dr. Alpan. I don't want it to hurt. I don't do well with pain." So I say, okay, no problem. We're going to use light forces, biologic. It's going to work with how the body responds. We're going to reduce the pain. It's going to be very easy. It's going to be simple. We're going to use night-tie wires. We're going to use passive self-ligating brackets. We're going to use Invisalign. We're going to use low-force system to apply low force over long periods of time, and we're going to be very efficient, and we're going to create the least amount of sensitivity. And by the time month 3 or 4 comes around, the patient looks at me and says, "Doctor, can you make it hurt?" I'm saying, well, what are you talking about? I thought we just had this discussion a few months ago, 4 months ago when we started, that you don't want anything to hurt. Patient looks at me and goes, "Well, that's true, but I'm just sick and tired of this treatment. I just want it over. So could you please just go as fast as you possibly can, because I want to get out of these things." And in the past, I would always say, yes, of course, we're going to do whatever we can, but it has to do with how your body responds. And so it's a, it's a wait and see, and we'll see you next time. And the typical response from the orthodontist is, well, yeah, maybe in a few more appointments. Or maybe as we get closer towards the summer. Or yeah, as we get closer towards the end of the year. And I could never really give them a ton of confidence, because I myself didn't have a ton of confidence, because every patient kind of responds slightly different. I'll have the big, huge physique person that responds really slowly, and I'll have the next person that responds really fast. So I think that Accelerated Orthodontics is definitely what we're looking at, and micro-osteoperforations is the tool that I want to talk about today. So this is a little statement about myself. I'm not employed by any dental company. I don't own stock or securities or interest in any dental company. My family member is not employed by a dental company or owns stock or securities. I've consulted or evaluated for products for different organizations, Propel being one of them, Ormco, 3M, Oral Care, and also Invisalign. I am a member of the Ormco Insiders Group. I finished my dental school in '96 at UOP, Arthur Dagoni School of Dentistry, and my ortho in '98. I got my master's thesis on a TMJ project that I wrote. I've been in practice since then, since 1999. I have 2 practices now, one in Los Angeles, one in Beverly Hills. I used to have one in Las Vegas that I sold last year in 2015. I was there for about 15 years. I already said I'm a member of the Ormco Insiders Group, part of the 3M Unitech Research Panel. I started using Accelerated Orthodontics in 2012. I'm a speaker consultant for Invisalign from 2002 to 2008. I was an elite premier provider for Invisalign since 2002, Center for Excellence Incognito provider, premier provider for Damon and Insignia, and also a key opinion leader and speaker for Propel since 2014. So I'm really, really interested in the most cutting edge in orthodontics. And part of the reason why is because I'm such a young person. At least now I'm not as young as I was, but the patients would come in and they would look at me and they would think that I was, I was an assistant. And so I always had to have things, in my opinion, that set me apart from other people, because it wasn't going to be my age and my experience and my gray hair. It was going to be something else. And so usually it was maybe Invisalign, or it was, Incognito or Insignia, or some kind of a digital platform, something that could kind of set me apart. And now I believe that what I'm really having a lot of fun with is Accelerated Orthodontics. I believe it sets me apart, and I think what it also does is addresses the issues that we as clinicians deal with on a day-to-day basis, and that is, how do we complete our patient's treatment to the best possible result we can get in the shortest period of time possible. So if you've heard if you've heard my presentation before, some of it will be a little bit redundant, some of it will be a repeat, but some of it will be new, and hopefully I put a new little twist to it if you heard the part 1. So this is part 2 of a 2-part seminar, but at the same time, I do feel that I have to review a little bit of some of what I talked about in the past just to kind of refresh people's memory. So this is my overview. It's going to be a history of accelerated orthodontics. We're going to talk about the science of micro-osteoperforations. We're going to talk about the animal and human studies, the advantages and fees, and then how to market, micro-osteoperforations in your practice. So a little history on the driver. So you can see that on the upper right-hand part of the screen, there's the blue one. That was the initial driver that was used. It was a one-piece unit. It was disposable. It had a depth measuring gauge on it. You can see at the end of the handle, there's some numbers there, and there's some lights at the other end. And it would light up when you would get to the depth. And it was a one-time use, and most of the doctors said, well, I'd rather have a sterilizable handle that's a little bit more sturdy and a disposable tip. And so the next driver down has that option where it's a disposable tip and it's a sterilizable handle. And so that was released, I believe, in end of 2000, and well, actually it was 2014. I think it was right at the AAO, and it actually won Pride Institute Best of Class winner in 2014. And then in 2015, there were over 350,000 treatments performed. It was featured in 18 different in our orthodontic or dental journals. And in 2016, is considered to be the leader in the science of acceleration. And I think that is what we're finding that's going to probably win out as far as any and all the techniques. And it's typically what we find in orthodontics is that when it has the most science behind it, it's usually going to have the greatest level of adoption. And so I would say as far as a tool in the world of accelerated orthodontics, it's really, really popular, and probably over the last couple of years, it's been one of the more popular topics to talk about at the meetings. Now, since us doctors are a little lazy, every once in a while we don't want to do too much at the chair, they did come up with a device that is actually automated, and that is the new driver, and you can see that on the bottom right-hand part of the screen. And that you don't actually have to turn your wrist. It's an automated machine, a device that will turn the screw for you. And so we'll review how that works and what the benefits are, which there are lots of them. So what is micro-osteoperforations? They're basically dimples. We're basically creating or stimulating a cytokine release. We're creating micro-trauma in a localized area to accelerate overall orthodontic tooth movement. And currently, it can be used in conjunction with any orthodontic modality. Invisalign, Incognito, Insignia, SureSmile, I mean, you name it, you can do it. You're moving teeth, you can use it. And the reason why is because we're functioning here with micro-osteoperforations on a biologic level. We're creating localized inflammation. The inflammatory response then creates the activation in the normal biology of tooth movement. And there's a picture at the bottom that you can see that we closed a molar space in, I think it was like 8 months. Didn't think it would even close to begin with those large tori. Obviously, it's a missing, second bicuspid, and we did use some TADs. Once the spaces were closed, the patient was totally ecstatic and happy. Didn't even let me, get the marginal ridge heights and molars totally lined up. But for, for big space like that, I think the patient was really happy, and so were we. So what are questions and statements that I ask or say when any new technology is presented to me? Should I be the first one to try it? Is there real science backing this up? Do I want to be an early adopter? Some of us have some hesitations on that. It sounds cool. Maybe we should wait and see. That's kind of what they always told us in school, right? Don't be the first one. Don't be the last one. Kind of wait and see how everybody else does, and then maybe you might jump in. And so I kind of put some pictures on there representing that confusion. The bottom right-hand picture of the guy sitting there, and arrows are going in different directions, doesn't know which way he wants to go or what's going to really happen here. It's kind of a funny picture. And then the next one is the science, and then the next picture is the sheep following up the hill. And so there's usually the one little sheep there, that's the leader, and then there's a couple that are right behind him, usually in that pack right behind that one. And some of us like to be in the middle of the pack, and some of us like to be at the end of the pack. And I'm not so sure it really matters where you like to be. The question is when are you going to get into that pack? Because I'm sure that as you can all see, that accelerated orthodontics is the wave of the future. The patients are asking for it. We're talking about it at all the meetings. All the doctors are doing it. And so somewhere along the way, we're all going to be offering some sort of accelerated orthodontics as an option for our patients. So don't be the first and don't be the last, and just make a decision when you want to jump on board. In my opinion, the sooner the better, because then you get to be part of the early adopter group and you get to participate in how to make things better. Some people don't like that. They want to wait till all the bugs have been worked out. It's kind of like when they release a new operating system. You know, do you just jump in and download it, or do you wait till the bugs get worked out? Nowadays, I think most of us wait till some of those bugs get worked out, and then after the operating system has been around for a year or two, then we go ahead and jump on it. And I think that's where we're at right now. Since it was released in 2013, it's already been that couple of years. So I think there's a lot more people and a lot more interest now that people are seeing that it's not going away. So where is the science here? Are we just traumatizing our patients, or are we actually really utilizing the biology of tooth movement? And so for the last, I don't know, 10, 16 years, something like that, there have been lots and lots of research that have come out that showed that the application of anti-inflammatory medication decreases tooth movement significantly. First was published in '88, then in '06, 2000, 2009. In animal studies, when they knocked out cytokines significantly, they saw a decrease in the rate of tooth movement. That was in '05 and '08. And there's multiple articles on this, and I think it's pretty well known now that if you use nonsteroidal anti-inflammatory drugs, you're blocking one of the mechanisms that allow tooth movement, one of the largest mechanisms that allow tooth movement to occur, and that is the process of bone biology in orthodontics, which is apposition and resorption. And so if we block the resorption aspect of breaking down bone by reducing inflammation, then we're not going to get the speed and the rate that we're used to with normal biology. So I would definitely recommend going forward that all orthodontic patients only use Tylenol for pain relief and they never use Aleve. Now, if you're going to be utilizing micro-osteoperforations, you're going to be using a driver to create localized inflammation, and the patient takes an anti-inflammatory. It does the exact opposite of what we're trying to create. Now, we don't want patients to have inflammation everywhere, and that's the beauty of the localized device that gives us the ability to indicate exactly where we want the inflammation to be created. Where is that tooth not moving? Is it an upper right lateral that keeps slipping out of my aligners? Or it's a lower right, first bicuspid that I can't get uprighted? Or whatever it is, I'm having a molar space that I want to close. I want to mesialize, a second and a third molar into a first molar space, or something difficult or challenging. We soften the bone, we create the inflammation, and then we make sure that the patient does not have any anti-inflammatory drugs on board. And usually what we're finding is that the effect of the increase of the cytokine release through our micro-osteoperforations lasts anywhere between 12 to 16 weeks. So if patients start getting on a little bit of the Advil or Aleve, that effect is going to go down dramatically and fast. So everybody knows the biology of tooth movement. We create tension. With that tension, it pulls on the PDL pulls on the osteoblasts get triggered. On the tension side, we're going to get cell proliferation, and on the pressure side, we're going to get constriction, and we're going to get resorption. And so on the tension side, we're always trying to create more bone, that we want the bone to form faster so that the tooth doesn't relapse and doesn't drop back. And so what we're finding is this whole process, or the biology of tooth movement, happens faster when we have more inflammation. And the reason why is because inflammation is a normal part of this process. When we create pressure, when we push that tooth over and it pulls on the PDL, that pressure creates inflammation. That tension creates inflammation. And that inflammation is what causes the teeth to ultimately end up moving. And what we're showing here in this picture is if we put too much pressure, then we get necrosis. We get a cell-free area, a zone of hyaluronization, which basically means that the cells in these areas are not getting enough blood, and so we're going to end up maybe causing some damage to the bone there, and then that resorption apposition process isn't going to happen in these two areas exactly at the speed or the rate that we want. So we have to make sure that not only are we respecting the biology of tooth movement with the forces that we use, but then we're also understanding how the biology works and not introducing chemicals to slow down that rate of tooth movement. So no NSAIDs. That's the bottom line on that. How does the science work? Well, stimulating a cytokine response basically increases the rate of tooth movement, and that was determined by multiple studies. And NYU came up with a study that showed using these MOPs increased the movement by 2.3 times, or led to 40 or 50% reduction in treatment time. And we'll review what that study was and what that showed and why that became so significant. But basically, bone remodeling has to do with many cells, right? We're dealing with blood vessels, monocytes, pre-osteoclasts, osteoclasts, osteoblasts, pre-osteoblasts, macrophages. And so it's going through resorption, reversion, formation, mineralization. All that has to happen in a healthy way. And typically when patients are healthy, which most of our orthodontic patients are, we typically will see this response happen in a very, very normal way. So we always talk about, you know, some general rules. We use approximately 150 grams of force. We apply that over, you know, a month time frame, and we see the tooth position move, and we can hang our hat on that we could potentially get 1 millimeter or less, you know, every single month. And that's very, very typical and very common for most of our orthodontic practices, unless, of course, you practice someplace where the water is special and the teeth move faster, like maybe New Jersey or something. I'm just kidding. What I have found is that bone remodeling in a younger patient happens much faster, and in an older patient happens much slower. And I'm not the only one. There's tons of research to back that up as well. And so bone remodeling is the basic element, or the limiting rate of what limits how fast the overall teeth can move. And sometimes it can be limited in one tooth more than another based on how far that tooth has to move. And then that tooth becomes the limiting tooth for the whole entire mouth. And that's what slows down the overall treatment time. And so I think that with localized ability to accelerate, you can actually have a pretty incredible effect on your overall treatment. So how do cytokines affect orthodontic tooth movement? Well, the application of anti-inflammatory drugs decreases tooth movement. In animal studies, if you knock out cytokines, it decreases the rate of tooth movement. Cytokines play an important role in activating bone remodeling, and bone remodeling is the basis for orthodontic tooth movement. So cytokines play an important role in orthodontic tooth movement. And so these are just various articles that I'm citing here, going all the way back from 1988 all the way to 2010, and then we'll even look at some more current articles. So what do we get when we do micro-osteoperforations? We're going to get bone injury, we're going to get inflammation, that's going to increase, we're going to get a cytokine production increase, we're going to get the rate of bone remodeling increasing, and the bone density overall is going to reduce, and so therefore we're going to see faster tooth movement with no negative side effects, or reduced dramatically negative side effects. Different modalities in accelerated orthodontics. So we have patient-controlled accelerated orthodontics. So the one on the left is the BioLux. It's the first version. It was the external device. Now there is actually an intraoral BioLux device that's currently being tested. This requires 20 minutes a day. It does rely on patient compliance, and it looks kind of almost like a headgear of some sort that you wear on the outside, or a face mask. And so this is out there, and this is something that people are using. Typically, we're finding about 30% reduction in overall treatment time with the light, which is a little bit less than the micro-osteoperforations, and of course dramatically less than Wilcodontics. Now, frequency of vibration is now a big issue, whether it's low or high. And you know, we all are familiar with this device here, and this device is a low-frequency device. It's made by Accelerated, and it's a rechargeable device. It requires the patient to use it for 20 minutes a day. It does rely heavily on patient compliance, and it costs the patient approximately $800 to $1,200, depending on which doctor is providing the unit. I think that acceleration in all forms has benefit, and I think that there's been research to show that there's benefit with all of these devices. The question is you know, the cost and the ease of use, and you know, what the patients really want. And so I think when we look at some of the other options like corticotomy, the Wilcodontics that I think people are very familiar with, where you're laying a full thickness flap, and it's very invasive, time intensive, a lot of recovery times, fairly high cost for the patient, and usually requires an extensive amount of training for the clinician. And it's just not something that orthodontists are typically doing. Most of the time we're going to have an oral surgeon or a periodontist that's going to perform the procedure. It is fairly traumatic, but we are seeing results as short as maybe 6 months for full orthodontic cases, which is pretty incredible. Typically, I have found that it's beneficial for patients that already have some kind of periodontal defects, and that when we're going in there, we're already going to be doing full thickness flaps, and we're already going to be fixing pockets and things, that why not incorporate that in there? Or if we just don't have enough bone, we have an extremely thin tissue type, then there could be an indication to potentially do some orthodontics to build up the bone there. Piezo surgery is a little bit less invasive, but it is still invasive. You're not decorticating or removing as much bone or creating as much trauma, but there is still trauma, and it does require a flap, and there is a fair amount of cost to it. I don't believe that it's as expensive as the orthodontics, but micro-osteoperforations offer something that the orthodontist can offer the patient. It is micro-invasive. There's no recovery time. It's maybe 24 hours. There's very little cost to the patient and the doctor, and there's very little training. And so I think that if you were to lay all these choices out in front of you, I think micro-osteoperforations really does offer something that the other ones don't, and that's the non-compliance factor. I don't have to really rely on someone doing something, and I can use it locally. I don't have to have it as a full mouth treatment. So micro-osteoperforation drivers create MOPs to stimulate a natural cellular response, harnessing a patient's own biology to accelerate tooth movement. And so there's the single-use device, the reusable handle, and then the automated device with the reusable handle. And so the handle at the bottom is an automatic device that makes that turns the driver to go forward or backwards. There are 3 speed settings. It has a very user-friendly LCD push-button display. It can reverse and go forward and is fully rechargeable. The threads are patented and designed specifically for micro-osteoperforations. And there's a video that your rep can show you on how to use it. It's really, really simple. And typically you would use it in combination with your assistant. So you would have, you would place the unit in the mouth, and you would then press the button to go forward, and then you would apply the driver, and then you would have your assistant reverse it, press the button, and then you pull it out. And it's actually very easy, and it's a little bit faster than some of the handheld devices that you have to apply the force yourself. And of course your hand doesn't get as tired when you use the automated one. But everyone should know that MOPs should only be created with device specifically designed for them. We shouldn't be just using our hand pieces, slow speeds, or things like that. They are not FDA approved, and there have been many instances of people necrosing the bone or getting tissue wrapped up in the burr and creating a periodontal little defect with the tissue there and the bone. Not only that, most of the burrs and things are really too large, and they're making too much space. The other thing too is that the bone doesn't need to really be removed. When we're using a driver like this, we're really not trying to remove bone, we're just trying to create trauma in the localized area. Whenever we use a burr or things like that, we will typically remove bone from the area, and then that takes a lot longer for that bone to have to fill in. So it doesn't actually always create the trauma that we want. It creates a different type of trauma. So MOPs with the power driver allows for easy access. It's got a really cool ergonomic design. It's great for torque. The speed is set specifically, so you aren't going to go too fast. You don't have to worry about that. It does have a surgical stainless steel tip, and like I said, there are some adjustable speeds on it. And I think it really is suited for what it is that we're doing. And it's cordless, so it makes it even easier. There's a contra-angle, there's a collar, there's a start and stop button, reverse and forward. You can change the RPM, you can change the torque, and obviously there's the power button. So it's actually pretty easy to use. The actual screw itself is specifically created for micro-osteoperforations with the patented stainless steel and the patented screw configuration. And so using the accelerator PT is what it's called. We can position the contra-angle, we can depress the head, and then we can just use the automated features to either cause it to go forward or reverse. And it's really, really easy to use, and if you want to have one of the reps come in and show you on a patient, I think that they'd all be willing to come in and help you with that. And if you want to just practice it on the little typodonts, you can as well. But it's super easy to use, and it's basically just a wireless or cordless slow speed that is very, very, very slow. It's not like a regular slow speed. Benefits of using micro-osteoperforation. So it's minimally invasive. This is performed at the chair. It's done in minutes. I usually am going to spend maybe 3 to 5 minutes at the most. My assistants are usually going to help with the topical and getting the patients ready. We can use it with aligners or braces. It does release difficult movements, so if you're having problems with your aligners, you can really unlock those difficult movements. It accelerates treatment, increases treatment predictability. There's no patient recovery time needed. It's doctor controlled, no patient compliance. Saves time, less offices. It means less time off work or school. Practice benefits, cutting edge technology, increased treatment acceptance. Patient always wants shorter treatment, no question about that. It does attract new patients. Patients today are looking for faster treatment times and practices that are embracing the latest technology. I think it incorporates a premium treatment option, and so therefore it should incorporate a premium treatment option fee. Reduced patient burnout, increased predictability of orthodontic mechanics. And that's something that I want to touch on today. I believe that now utilizing my micro-osteoperforations, I'm actually able to accomplish things that maybe I wasn't really able to in the past. Maybe movements that really were ideas that I would like to accomplish, but really not something that I could predictably and reliably accomplish. And so that's really what I'm going to talk about when I start showing some of my cases, and that is that we all think that we just want to use it for one purpose, and that's to speed up treatment. But I have some scenarios where I'm using it where I'm just trying to get the most optimal treatment result that I'm looking for. So it may not save me any time, but it may get me the result that I'm really looking for that I probably couldn't get any other way. And so therefore, not only does it reduce treatment time, not only does it reduce, the amount of effort and energy that you have to spend working on the patient, it reduces your overall chair time, increases your efficiency. Let's look at what the studies show. So the animal studies in the rat jaw, that is a rat jaw, showed that in the control that there was no movement at all, and they looked at the cytokine release in the bone, and they looked at orthodontic movement and what happened there, and they looked at orthodontic with perforations. And so not only did they see an increased cytokine release, there was also a dramatic change in the tooth movement with the perforations versus no perforations. Of course, everybody says, well, it's just a rat jaw. Let's look at it in humans. But the expression of these cytokines, and there are multiple, you can see here all the yellow lines, each one is an individual cytokine that they're measuring. And the yellow is the ortho plus perforation group, and the white is just the perforation group. And we can see that on these bar graphs, and all three of them, that the ortho with perforations all responded greater. In other words, there was a higher cytokine response when measured in compared to the rat jaws that just had orthodontic movement. And so when we look at the microscopy, we look at what's going on a cellular level. We're seeing the control shows very little cellular change in the bone. And then the orthodontic movement, we're seeing more cellular activity and change in the bone. And then the orthodontic with perforations, there's a dramatic amount of proliferation and changes that are going on in the cellular level. And so we can see that with perforations, we're going to get a greater response from the bone remodeling. And here's another picture looking at the control, the orthodontic group, and then the ortho with perforation. So on the bottom picture, you can see a lot more proliferation, a lot more cellular changes happening with the perforations. Here's another look at Osteoclast. And so there's the control group looking at the bone and the changes there. And then there's the orthodontic group, and you can see the changes in the bone and the activity. And then the ortho with perforations, I mean, you can really see a dramatic amount of change in the periodontal ligament and bone interface there with these slides. When we looked at the canine retraction, we found that in the osteoperforation group, we got the highest amount of cytokine response than in comparison to the control. So with perforations, we're always seeing a greater amount of cytokines and a greater amount of canine retraction. So it was almost twofold the amount of canine retraction in the osteoperforation group than in the control group. In the human studies at NYU, this is the Alpan article that I was making reference to at the beginning. This one pretty much kind of changed how we were looking at this process. And what they did was that they looked at how could we look at an individual and get this information. Normally we want to look at a large sample size, right? A sample of 30 or something. In this situation, they just did a split mouth study. So on one side of the mouth, they did canine retraction with no perforations. And on the other side of the mouth, they did canine retraction with perforations. And so the side with perforations responded dramatically faster, 62% faster, or 2.3-fold faster. Now, of course, the study was only done over a 1-month time frame, and so it didn't look at the overall treatment time, but it did look at what happened within one person's mouth. So you can see this is the right side. This is just ortho. And what they did is they set up a little power arm with a TAD and a TAD spring. And they really tried to measure the force to make sure that the force was the same on both sides with the power arm. And they tried to design it exactly the same on both sides. And the side that had the micro-osteoperforations is the side that responded faster. And you can see that there on the bottom slide, is that there was more space and more canine retraction on the side with the perforations than there were with the other side. Now, like I said, it was only done over 30 days or so. And so what I'm finding is that even though this research showed 62% reduction in treatment time, it was looking at only a very small time frame. And so what I'm really finding clinically is about 40%, sometimes maybe as much as 50 in some cases, but about 40% is the number that seems to be working for the whole case, for the whole treatment time. So it was a really great study, and it really kind of showed that in the same mouth you could get a greater result by introducing these osteoperforations. And that's the measurements there on before treatment, cytokine level, 1 day in treatment, 7 days in treatment, and 28 days in treatment. And so it doesn't matter whether it's 1 day, 7 days, or 28 days. With the osteoperforation group, you're seeing a higher level of cytokine release. And if we know that the cytokines are related to the bone resorption, then we like those cytokines. We want more cytokines. Give me cytokines. Move those teeth. Orthodontists and patients alike are interested in techniques that can accelerate tooth movement. This article came out in April 2014. Everybody wants to get the treatment done faster. Patients, the doctors, everybody, even the insurance companies, I believe, probably want them to get faster because they're probably looking for a way to find a way to pay us less money. But the world wants us to get our treatment done faster and have no negative effects or side effects. And so in the past, before we had options, the patients would ask us, and we would say, oh, well, I don't really know. Or maybe what we would try to do is see them a little sooner. Oh, maybe we'll see them every 3 weeks, see if we can kind of activate the chain a little faster and see if that gets things going faster. And sometimes, applying more force over a shorter period of time actually created that bone necrosis and the hyaluronization and didn't actually help us with moving teeth faster. So applying more force didn't actually create the result that we were looking for. And with accelerated orthodontics, we are not going to apply any more force than we normally do. We're going to apply the same level of force as we always do to move teeth, and we're going to find the teeth will respond faster. How many articles are out there on MOPs or micro-osteoperforation? Many, and so this is one of them that was published in 2013 by Pobans, Nicozizi, Storino, and so there's another article here, summer 2013 by Dr. Miraglia. Another article in Orthotown, July, August 2013 by Nicozizi, Accelerated Tooth Movement Technology. Another article in the AJO-DO, that was the one I made reference to, the effect of micro-osteoperforations on the rate of tooth movement. The Alpan article, that was sort of the landmark article that came out in November 2013. Another article by Miraglia in November 2013, Propel Orthodontics Enabling Predictable Results, came out in December 2013. That was by Karen Gwynn. She showed some really cool cases. I actually have a couple of them at the end with impacted canine exposure and bringing those impacted canines on an adult in faster, and then also for intrusion of gummy smiles. She showed some really awesome results in that article. Shipley's article, the use of Propel to increase the rate of aligner progression. He goes as fast as 3 days through his aligners, sometimes 5 days, depending on what's going on with the patient. But 3 to 5 days to change aligners is really, really fast, and he shows some incredible results and even has some pictures of CBCT before and afters with micro-osteoperforation, and even has a couple of those images showing what happens to the bone over time as it heals. And so that article was in March of 2014. And then my article, Accelerating Treatment, was published in Orthodontic Products. It was published in May of 2014. And basically it talked about the biology of tooth movement and what some of my research was back in dental school and ortho school, and then how things have changed and how I've incorporated accelerated orthodontics into my practice. And I do talk a little bit about some of the other techniques to accelerate tooth movement in that article. Let's see, Nick Azizi came out with another article, June of 2014. You can see a pretty incredible skeletal change in that case that he shows. And so there's lots of published, and that last article was, I think, 2014, end of 14. So in 2015 there have been more articles published. In 2016 there are already some being published. In fact, I was just invited to write another one here in June to be published in September. So it's really something that people are interested in and people want to know about, and they want to understand what it is that they can offer to their patients. So Micro-Osteoperforation Technique. So let me just kind of let you know that the technique is really, really easy. There's a little guide, and this is like a little sheet, a little flow chart, and one, you evaluate where you want to place the perforations. The next is you want to make sure that the mouth is super clean, so you'd have the patient rinse with Paradex. And then the next is anesthetize the patient, and you don't have to use a syringe to anesthetize the patient. You can use topical anesthetic to anesthetize the patient. Some patients do require a syringe, do require a little bit more profound anesthesia. A lot of patients will just go fine with just a regular benzocaine topical and then a more profound topical like a prilocaine mixture, a compounded topical. Some patients do require the syringe. And so there's a little flow sheet there. And then, of course, when we're done, we always give them the instructions on please don't use any NSAIDs, Tylenol only. Makes it work better. So this is a little closer up, 3 easy steps in minutes. So evaluate the area, palpate the tissue, evaluate the x-rays. If you're going to be going into the attached tissue or maybe a little bit into mucogingival tissue, you're probably not going to be getting anywhere near the root apices. But you do want to clean the mouth. Chlorhexidine rinse, have them do it 2 times for 1 minute each. Anesthetize and perforate. So you want the treatment area can be anesthetized by using regular topical or local, or a compounded or a combination. And what I did was I left the compounded topical on the lower right-hand side. It seems to really work the best. And if you need a recommendation of where to get it from, I think that there's a compounding pharmacy in Woodland Hills that creates the stuff. It's called the baddest topical in the West. I think that literally is the name of the topical. If you want to just use that formula and have someone close by, that you have a relationship with, make it. You can do that as well. Micro-osteoperforation depths are usually determined by the soft tissue thickness and penetrating the bone at about 2 millimeters. So if someone has very thick tissue, you might go 4 millimeters in, or you might go 5 millimeters in. Most of the time, we're really not going 7 millimeters. So we're usually between 3, 4 to 5 millimeters, and we'll show you some pictures of how that works. But typically, once the patient is anesthetized, you do want to check to make sure, with an Explorer or something sharp, to make sure that they're just not going to feel it. There's nothing more fun than having the patient start squirming around. Just kidding. I always make jokes about that. I think I can levitate, or I can do magic because I can watch the patient, their back kind of arches and they kind of start to lift off the chair, and they almost like they're levitating. Of course, that's not ever really what we want to do in orthodontics. We always want them for it to be painless, but sometimes you do an intraoral, arch wire adjustment, and they start to levitate a little, or you do a little propel, and you get a little levitation. And so, some of my patients call me a magician. I think I'm just doing, orthodontics, but some of them call it magic. The technique. So there's the single-use driver. There's the reusable driver. There's some pictures there that kind of show what it looks like making perforations. Ultimately, I think that you just have to try it to really get accustomed to it, and you'll find that it's a lot easier than you think. I think the first time I looked at it, it was kind of like the first time I looked at IPR. Oh my God, I'm going to be cutting teeth. I just spent my dental, career learning how to save enamel, and now I'm going to cut enamel. And once you get over that hurdle and you recognize that if you do it in a conservative way, it actually creates incredible results and deals with two-size discrepancies and creates nice, flat, broad surface areas, and teeth tend to be more stable when you're done. You're like, well, wait a second, IPR is a normal armamentarium, or part of my armamentarium as an orthodontist, and so is Propel, or micro-osteoperforations. Treatment considerations. Most patients require 1 to 2 treatments. Complex cases may require 3 treatments. Very, very rarely am I ever going 4 treatments. I mean, that's pretty rare. 2 to 3 MOPs are recommended mesial and distal to the teeth. Osteoclastic response is usually going to be about 6 to 10 millimeters from around the treatment site or the area where the perforation was done. For acceleration, perforate around the rate-limiting movements, or the teeth that are going to be the most difficult to move, and don't perforate around the teeth that you don't want to move. So what you can do is you can actually use that as a way of creating anchorage. So if you want to move your anterior teeth, then perforate all the anterior teeth and don't perforate the posterior. And if you want to move your posterior teeth and you don't want to move your anterior teeth, then go ahead and perforate all the posterior teeth and don't touch the anterior teeth. And then you just set up your differential anchorage. So there's a lot of cool things about micro-osteoperforations. The depth selection is typically in the anterior 3 millimeters and the posterior 5 to 7. If you are going through the palate for impacted cuspids, which is probably the only time I do it, you may end up getting in a little bit deeper, about 7 millimeters. And the reason why is because the tissue there is dramatically thicker. Osteoclastic effect peaks at about 24 hours and remains elevated for 10 to 12 weeks, and I've even seen some stuff now that's showing as late as maybe even 16 weeks. So treatment could be repeated at the 12-week or even 16-week. So sometimes we've even gone as far as 4 months in between treatments. And there's sometimes where I'll do one and we'll get the effect, and then maybe the patient doesn't want to do another one. And I'll even show you a case where we waited, more, maybe 6 months, and then we did another one, and then the effect kind of ramped up. Of course, the effect really ramps up if you do it, and then 3 months later or 4 months later you do it again. Then it kind of stays, that cytokine level stays high for a longer period of time. How many micro-osteoperforations? So you could see in this slide there's 3 vertical, 1 here, or 2, or 3 kind of like in a triangle or a tripod. It doesn't really matter how you're doing those holes or how you're doing the perforations, just as long as you're creating the perforation. You want to break through the tissue and perforate the bone and create a little microfracture in the bone. And that little microfracture causes that trauma and basically radiates out for about 6 to 10 millimeters on both sides of wherever it is that you place those perforations. Now in this picture, there are showing perforations in the middle or in the midline between the centrals, and I usually will not do that. And the reason why is because there's usually a frenum attachment there. And so I tend to stay away from making perforations in the soft tissue where there's frenum attachments. So in the middle of the upper centrals, I usually stay away from. The lower centrals, depending on where the frenum attachment is, usually it's a little bit lower. And then sometimes on the upper or the lower, around the 4 or 5 region, sometimes there could be some longer tissue tags or tissue pulls on the soft tissue. And so those frenum you would want to not perforate, just my opinion. How deep to perforate? We talked about it, 3 to 7 millimeters. Typically it's going to be about between 3 to 5. It kind of depends on where you are. As you go deeper into the vestibule or closer towards the apex, you are able to go deeper, but I'm not so sure that anyone really has shown or proved that by going deeper you're going to have a greater effect. And I think part of the reason why is because as you go deeper, you go into medullary bone, and really how much are you going to distract or shake up in there versus the cortical plate. And so when you're cracking the cortical plate with the micro-osteoperforations, that's when you really are getting the trauma that we're looking for. When it starts to screw into medullary bone, it's not going to create that much trauma, and so therefore I don't think the depth, going super deep is really the issue. When we have TADs and we want those screws to stay in there, okay, well then we want a certain amount of depth for mechanical leverage for it to stay in. But with a propelled driver, it's not really about depth. It's just about breaking that cortical plate. So where do you perforate? Micro-osteoperforations can be performed either buccally or lingually. Typically, most of them are going to be done buccally for me. The reason why is I have good access. It's the simplest approach, and usually that's where I'm considering how I'm moving teeth around is from the facial, and that's also where the thinnest bone is. So you'd have the greatest effect of your micro-osteoperforations is going to be on the facial. As you do them on the palate, you're further and further away from the tooth. You'll have a little bit less of an effect. But you can see pictures there of perforating in the palate and pictures perforating on the labial mucosa. Most of the time I try to get an attached tissue, but sometimes the attached tissue is just not enough and I have to go into the mucogingival area. And so there's another sample showing you. You can see how the driver is going into the attached tissue, and this is what it looks like after the driver is removed. There's a very, very small hole, and that hole usually by the time the patient leaves is already sealed and they're not bleeding. Sometimes there might be a little bit of oozing of some blood, and you just have to sit there and apply a little bit of pressure, usually no more than 20 seconds or a minute to get them to stop bleeding. If someone has a little high blood pressure or things like that, then it could take a little bit longer, but of course you'd want to do those screenings prior to doing any invasive procedure. Post-treatment instructions. So when the patient experienced some tenderness around the treatment site for 1 to 2 days, make sure that you really stress no NSAIDs. They can take Tylenol, but no NSAIDs. Micro-osteoperforations can be repeated 10 to 12 weeks. Nowadays, we're even going as much as 14 and 16 weeks. Post-treatment instructions are similar for local or topical anesthetic. And so one of the things that I should tell you about that very profound topical, you should know about, maybe I'll go back to that. That profound topical is so profound and so strong, if you leave it on the tissue for more than, depending on which formula you're using, some formulas it's 30 seconds, some formulas it's a minute. The baddest topical in the West, it's like I think it's like 3 minutes to 5 minutes. Anything more than that, then it starts to cause the tissue to slough a little bit. So you do want to be a little bit cautious. I usually won't have my assistants place the profound topical, but I will have them place the benzocaine topical, and then I'll come over and place the profound topical. Where are we? Here we are. Micro-osteoperforations with aligners. So one of the really cool benefits is that when you start to perforate for a patient with aligners, you can give them a bunch of aligners. You can really increase the appointment intervals. Let's say you want to see them back in 6 weeks, you give them 6 aligners. You want to see them back in 8 weeks, you give them 8 aligners. You want to see them back in 10 weeks, you give them 10. And typically that's what I'm doing. It's about 7 days per aligner. I know Shipley talks about 5 and maybe even as low as 3 days. And I think on very easy, simple cases, you probably could shorten that time frame and get the same treatment results. When you start to get into much bigger, more complicated movements where multiple teeth in the mouth are moving and you're dealing with AP corrections of transverse problems, I like a 7-day interval. It does avoid refinements. It avoids mid-course corrections. It does expedite treatment results. Reduces aligner lag, so you'll see less of those issues with the teeth not tracking properly. It keeps the cases on track. It increases treatment predictability, and it can facilitate challenging aligner movements and overall reduces chair time and increases profitability. So I look at micro-osteoperforations in 2 ways. One is proactive acceleration and one is reactive acceleration. So proactive is we're starting at the beginning, right? When we first start the treatment, we do 7-day intervals from the start. We perforate the desired area and provide the patient with the aligners. We schedule the follow-up visits accordingly. So it's a 7-day interval. We'll give them 6 to 12 aligners to get through, and then we'll schedule the follow-up visits every 6 to 12 weeks. We schedule the second acceleration, usually is going to be on aligner number 12. And so that's typically how we do it. So it really reduces the number of overall visits to the office and allows us to have the patient change to their aligners a lot faster. One of the biggest complaints with aligner treatment is that usually after 1 week, the patient does complain that they don't have, they're not feeling any more tension. And so it's something that keeps the patient motivated because now they're changing out their aligners every single week and they get really excited about it. And then you can dispense more aligners, and because the aligners are already, the movement is already programmed into the treatment, you already know where they're going to be going, you can feel a lot more comfortable about giving them more aligners and seeing them a little bit later. So instruct the patient to call the office if the aligners don't fit the same as the initial visit, record dates on the aligner bags, and instruct the patient when to change out the aligner. So we usually do that for them and make it real easy for them. Now, reactive acceleration is done after the patient is already in treatment, kind of like the patient that I was talking about right at the beginning of the presentation, right? 4 months into treatment, they're saying, doctor, make it hurt. I want these things off. I want to go faster. And so now I can say, you want to go faster? Great. Let me introduce micro-osteoperforations. Let me show you what it is. Let me show you what it can do. We can do maybe 2 in your treatment, and we can knock off maybe several months of treatment. And so we usually, once we do it, we're going to deliver 4 aligners. We're going to schedule a follow-up visits in 4 weeks. We're going to dimple the aligners, or we're going to use auxiliaries as needed. If they're using elastics or auxiliary buttons and things like that, they're going to do all those same things. But typically, we're going to be changing the aligners faster And in the first one, I'll see them a little sooner in 4 weeks, and then I'll start to put them out a little bit further, maybe go 6 weeks or 8 weeks in between appointments to kind of finish up the balance of their aligners. So micro-osteoperforation with brackets. It's pretty much the same benefits with aligners, except for you can't schedule the patient out as far. So the patients with braces have to be seen usually once every 3 weeks, and the patients with Invisalign, for example, could be seen 6, 8, 10, sometimes even 12 weeks in between appointments. And the reason why is because you already have the aligners already pre-programmed. With your fixed appliances, you're going to have to change a wire, or you're going to have to reposition a bracket, or you're going to have to retie a chain, or you're going to have to do something else to activate how the teeth are going to be moving. So you'll end up seeing them a little bit more often, but it will overall reduce chair time. It will increase profitability. Promoting Accelerated Orthodontics to your patients and your community sets you apart. Your treatment plan could actually become more difficult with movements that become more reliable. And so that's one of the arguments I'm going to make here, is that maybe we don't use micro-osteoperforations to get treatment done faster because maybe there's a faux pas in the way that we see it, or that's not cool, or that's not good. Maybe we just use it to do things that maybe we probably couldn't ever really do unless we were doing like surgery or things like that. And so I'll show you some really interesting scenarios where we used micro-osteoperforations to achieve results that we probably wouldn't have been able to achieve without it. So what do we find on proactive accelerations? It maintains the same biomechanics, decreases time between appointment intervals to 3 weeks. This is for braces. Level and align faster with more predictable treatment outcomes and reduced treatment time. Perforate mesial and distal to the sites, various teeth. Only required in areas of difficult movement so you can set up your anchorage. Accelerate when arch wire is engaged, and perforations can be made 12 to 16 weeks apart. Reactive acceleration, again, maintains the same biomechanics, decreases time between appointment intervals. We've even seen people as fast as every 2 weeks once we start getting into reactive acceleration. Resolve difficult movements holding up the finish. Perforate mesial and distal, only required in difficult areas. And we are perforating a little bit sooner because we don't have the whole treatment time. We're already behind the 8 ball here, so we're going to probably perforate more like on a 10-week cycle. So malocclusions that you can treat with micro-osteoperforations, I think that's all of them. There isn't anything in regards to moving teeth that we couldn't use MOPs for. And of course, everyone nowadays is all about their picture-perfect selfies and how could they get there faster. And so this is one of the marketing campaigns through Propel that they talk about how do these gorgeous people get their smiles faster. And of course, that's what all of our patients want. So now to the fun stuff. This is actually, I call it my human studies, but really that's actually treating my patients with using micro-osteoperforations. And so the patient on the left side is not the same as the patient on the right. The patient on the left just had a really big diastema, and literally within like four months or so, we ended up closing the diastema. And we finished the case really fast, and we did see her on a 2-week interval. And we ended up doing one set of micro-osteoperforations, one set of MOPs. The second patient, funny enough, as I began to treat him, his head actually got smaller. I'm just kidding. It was funny when I laid this out in Dolphin. That's the way that the superimposition of the 3 photos, before and after, that's how it just laid it out. And so I just thought it was kind of a funny way that it laid out. I figured I'd keep it, as the spaces got smaller, his head size got smaller. But really what happened there is, and the first picture to the second picture was almost a year, and I swear I got no change, or very, very little. And then once I introduced the MOPs, I started getting big change. So let me show you exactly how that case played out. So this is reactive. In other words, I didn't do it right at the beginning. This patient started in March of 2010, so MOPs and Accelerated Orthodontics were not quite released yet. The studies about the NSAIDs were, and so at that point in time, doctors that were charging for overtreatment were also advocating lots of Advil. Funny enough, this particular patient, you can see what happened. That's March of 2010, and this is January of 2011. It's almost a year later, and I swear none of the spaces have closed. And there's got to be a reason for this, and I don't think it's my biomechanics, because I've reviewed the biomechanics with other people, and other people have said that doesn't really make any sense. Like, for example, if you look at the maxillary intraoral photo, you can see 2 to 2, there's no kinks in the wire at all, and all we're doing is trying to power chain and bring those teeth together and close the diastema, and we've been doing it already for almost a year, and it's not closing. Same on the lower. So if we were talking about maybe trying to close space between the lateral and the cuspid, well, you can see there's a little bend there, just mesial to the cuspid, which would make it impossible for us to retract there. But as far as the space between the 2 to 2, that should get closed. That shouldn't be any challenge. So we introduced one set of MOPs. We did it in January of 2000. Or excuse me, we did it in August of 2013. And then this is our progress photo from March of 2014. At that point, I wasn't quite taking pictures of everything. But you can see a dramatic change. We're actually getting space closed. And that's our progress in July of 2014. Majority of the spaces are closed. We still have a little bit of some issues with our cuspids. And this is our final image in December of 2014. I still wasn't totally happy with the shapes of the cuspid, but we did finish in a nice molar-cuspid relationship, and then we ended up, I tried to convince him to go do some bonding to fill in the spaces and kind of reshape the cuspids, but he said that he was so happy with his result he didn't want to change it. This lower left molar was broken down when we first started. Same with the lower right first molar, had a crown. It was pretty flat. I asked him to have that redone. He decided he didn't want to do that either. So he was pretty happy with the way that turned out, and I was happy that I was able to offer him something to help me finish the case. I probably wouldn't have gotten all those spaces closed ever if I didn't incorporate something to stimulate the body's biology. So here's another case. This is a reactive scenario. So this patient was started in May of 2010. And of course, I only have 1 or 2 easy cases. So I'm sorry, I apologize in advance that I don't have a lot of easy stuff to show you, but that's just not, to me, what's relevant on a day-to-day clinical scenario. Easy isn't just what walks in anymore. Easy is what doesn't come in because somebody else is treating them, and difficult is what walks in now because we're specialists, and this is what we do, and this is what we do well. And so when I look at this patient, I look at those incompetent lips, and I look at that hypermentalis, and I say this person's face is not looking good. And I look at what's going on. Dentally, yeah, she's got some crowding, she's got some protrusion, she's got some missing teeth, she's partially edentulous, she's got a posterior open bite, she's got a posterior open bite on both sides, and she's got a posterior cross bite. And so, of course, I don't think that this case could be any more difficult. So there's the Ceph. It started in May of 2010, pretty by max. I'd call that protrusive. You can see that the lips are having an effect, and the mentalis strain just to keep the lips together. So we decided that we're going to extract teeth. And I know some of us look at me and say, what are you talking about? She's already missing teeth. You're going to be extracting teeth? And I think I just had no choice because of how much protrusion she had. So we did decide to extract some upper bicuspids. And so that's what we did. So there's the pano showing the bicuspid extraction. And so if we go back, that was May of 2010. This is now November of 2010 with the extractions done and leveling and aligning starting to occur. And here's January of 2011. We're doing more leveling and aligning, trying to consolidate some spaces here a little bit. And so this is a progress photo of April 2014. And we did 1 micro-osteoperforation in May of 2013, and we did a second one in July of 2013. And so you can see here now that all the spaces are closed, or majority. There's a little bit of space here on the lower right side. Majority of the spaces are closed. Majority of the bite is resolved. The right side still has a little bit of a class 2, and her profile is looking dramatically better. And I don't think I would have been able to get all those spaces closed without using those micro-osteoperforation. So here's May of 2014, more space closure, a little bit more improvement of the class 2 on the right side. This is what it looks like on the pano. Everyone's probably wondering, oh, you dragged all those molars forward. You probably end up with a lot of resorption on the roots, which I can't seem to see. And so I think it turned out quite nice. I was actually pretty impressed with the way that this turned out. Of course, I don't think that this was, shaving a lot of time off. I mean, this is like a 4 or 5 year case. But at least we're actually going to get done. And so here July of 2014, you can see the class 1 canine and class 2 molar on the left side, and on the right side we're still a little class 2 cuspid, getting better on our molar relationship. And this is what it looked like when we finished. She just got to the point where she said to me, Doc, I'm done. I don't want any more treatment. And we did end up using TADs in all 4 quadrants. We used TADs also on the upper right side to level the cant. And so it was quite a complicated case, and that's what it looked like cephalometrically when we were done. I think it turned out great. I think her profile and her lips turned out really nice. I think she has a really nice dentition. You know, she has first and second molars. She's missing her bis, but I think that it turned out great with her profile. And so this is a scenario that maybe I didn't shave a ton of time off. I mean, you know, I wouldn't call this a fast case. This isn't like I go to some of the seminars now and, oh, I finished this in 3 appointments, and yeah, this isn't one of my most efficient cases, but it is pretty cool. So here's 5 of 2010. That's what she looked like cephalometrically. That's what she looked like radiographically with, you know, missing first molars. And this is what she looks like at the end. I was pretty happy. The little midline discrepancy bothered me. She got to a point where she just said, no more, Dr. Alpan, thank you very much. But I think that her bite turned out good, and I think that her smile looks really nice, and I think that we created some nice improvements. And of course, this is with a combination of you know, passive self-ligation, TADs, and micro-osteoperforation. So it's kind of a lot of technology in there. That's the final ceph of September 2014. That's the final pano. Nothing really out of the ordinary. No major root resorption. A little bit, maybe some periodontal defects that she needs to be working on. I don't think it was created by the orthodontics, but so let's look at additional case. So this case, this is my, you know, oh, this is the easy one, right? The patient walks in. This is going to be so easy. I can do this with my eyes closed kind of case, right? And the patient walks in, and you're thinking, oh man, I'm the hero here. You know, this patient's got some spaces, and I'm just going to resolve those spaces like it's nothing. And then I look at her ceph, and I'm like, oh, what's going on here? This patient had surgery. She had a Lefort procedure done. She's got plates in her upper jaw. And so when we started in November of 2012, this to me did not look difficult at all. This looked extremely easy. Class 1, molar cuspid, no cross bites, midlines are aligned, and all we have is a little bit of spacing on the upper arch. We've got a little two-size discrepancy. Big deal. This is going to close in a heartbeat. So here's obviously you guys can tell by the way I'm describing it that it wasn't that easy, but there's the ceph, and you can see on the pano that the plates don't seem like they're anywhere exactly, well, maybe this one, but they're probably not going to interfere with our space closure in the front. So November of 2012, now we're in May of 2013, and guess what? The spaces are just not closing. You know, and I'm not using, you know, chicken mechanics. I mean, I'm using double, you know, Nai-Tai springs there, and I'm using power chain, you know, using closing loops. I mean, this is not a light level of force that's being placed on this upper arch to close all these spaces. So we ended up doing a micro-osteoperforation in February of 2014. So here's June of 2014. There's June 27th of 2014, and there's September of 2014 with all the spaces closed. So if I back up just a little bit, there's our May of 2013 pano where I'm going, there's something's wrong here. Why aren't these spaces closing? I don't get it. And then this is when we did the perforations in February, and then you can start to see the spaces close, and they're closing, and they're closing, and they're closing, and now they're closed. And so we got done in October 2014. All the spaces closed. Patient was really happy. And of course, we did only one micro-osteoperforation. So this is another scenario that was a little bit also challenging. Here's a transposition. You can see the lower right cuspid is transposed between the lower right central and lateral. And this is another reactive micro-osteoperforation case that I did with passive self-ligation and TADs. I used multiple TADs in this situation. And part of the reason why is because I've finished several cases where I allowed that cuspid to erupt right in between those two teeth, and I finished it that way, and I thought that that was the gold standard. That was pretty much the way we had to deal with transpositions or transposed teeth. And so in this situation, I decided after I have finished many, many cases that I didn't really like that canine came into the right place, and I decided I was going to do something outside the box. I was going to use Propel. I was going to use passive subligation and TADs to intrude the cuspid, bring the cuspid around the lateral, and allow the cuspid to erupt into the correct position on a child or adolescent where the roots were already formed. So, you know, just kind of stacking the cards a little bit against me. take a look at what happened. This was in August of 2011. The patient, the mom sent a pano over. I didn't even do an exam, and they said, "Is there anything you could do with this cuspid?" And I said, "Yes, I probably could. Let me see. Have the patient come in. Let's do an exam." So this is August of 2011. Patient comes in January of 2012, and you can see what she looks like. The occlusion doesn't look anything real strange, but we've got a deciduous cuspid, and the permanent cuspid is impacted. And so this is what it looks like on the Ceph. She doesn't have an AP issue, but you can see the impacted cuspid there. And this is January 2012. And so you can already see, and by the time January 2012, the tooth has erupted a little bit more and has gotten a little closer to the into the mouth, which of course makes it a little bit more difficult to do what it is that I want to do. And I'm not so sure what I did here has ever been done before. And so this is what it looked like, progress of May of 2012. I ended up sending her to a surgeon because the chain came off, and we had to have it replaced. And the surgeon couldn't quite get primary closure, and you can kind of see what a mess this made. And it actually ended up creating some problems for us down the road. But the other thing too is that the surgeon didn't understand when I said, "Please place the chain between the lateral and the first bi." So the surgeon ended up wanting to place it basically between the lateral and the central. And I said, "Well, that's not really where I want it." So we ended up having some fun discussions over it. And she said it was going to be absolutely impossible for me to bring that tooth over. And I said, "I'm sure it is, especially subgingival, where you can't really see what's happening." And she said, "Yeah, exactly, subgingival. Good luck." So I said, "Okay, let me see what I can do." So you can see the little chain here in this pano. This is now July of 2012. And the chain is still left there because I didn't want to take the chain out and ruin the tissue there, like she had ruined it before in the other area. And so what I decided to do is I placed one TAD between the lateral and the first bi, and I placed a second TAD between the lower right first bi and second bi. And I used one TAD as kind of like a lever to create directional force the way that I wanted the cuspid to move in. And so I initially placed it so that I could actually intrude the cuspid, and then place the TAD so that I could actually bring it over, and I did it all subgingival. So this can't really be shown too much on the outside because it's all happening under the tissue. And so here's the pano on October of 2012. Here I am pulling that cuspid over. The second TAD again is just to help me so that the spring doesn't go up, and so that the force stays in the direction, the horizontal direction that I want it to stay in. And so here you can see that I'm successfully pulling that cuspid over. And here's January 2013. I've now got the crown almost in the right place, and the root is kind of falling behind, and I've already taken out the second TAD, and I've left the first one. So a couple of these TADs I actually had to move and replace a little bit. So this is a PA showing in August of 2013. The crown has been dragged over into the right scenario, and you can still see that the root of the lateral is intact and the root of the cuspid is still intact. So I'm feeling like, okay, my mechanics is working out here, even though it is quite complicated. And so what I now have in this picture here is where we did our first propel. And so propel was done in October of 2013. It was done on this patient because her lower right cuspid was sitting in such an angle where the root apex was almost in the middle of her mandible. And so I had to now bring the root apex all the way around and bring the cusp up. And so I had to use a power hook, and we still use one of the TADs to try to pull that root around. But I figured that's a lot of bone remodeling. Why don't I just soften all the bone around there and see if that helps us? So we did a little propel there. And this is July of 2013, where the tooth is a little bit more upright. And we ended up pulling from the labial and from the lingual. We added some buttons on the lingual, and we pulled it in from the lingual as well. So this is November of 2013. This is March of 2014. And here we have our second propel. And we basically did it on both sides and a little bit around the first bi and the lateral. And basically what we want to try to do is really kick that root over and close this open bite, which she didn't have when she started. And I believe that all happened from utilizing the TADs and pushing so much on this lower right side that we actually got some intrusion there. So she had to wear some elastics to pull that up. And this was April of 2014. Again, you can see we're using a TAD here with the tooth to try to bring that root around with some light wires. And there's October of 2014. We got a little bit of some recession on that cuspid, but overall things are coming together nicely. And this is what it looked like when she finished. So that was January 2015. We got the cuspid in place, and that was literally right when we finished, and there was a little bit of some recession. I don't have the post-op picture, which I'm going to get. She ended up spontaneously improving a little bit there, which I'd like to show everybody. But let's look at the pano. So everyone's probably wondering, oh, there's no more root left in that lateral, but it looks like pretty much a pretty healthy root for that lower right lateral. Maybe 1 or 2 millimeters shorter than the contralateral side. Definitely the cuspid, the root got a little shorter than the contralateral, almost by 3 millimeters of resorption, but the tooth looks like it's in place, and positive crown root ratio. So I think it was quite an interesting case there. So just if you want to go back and see the pano again, where we started, this was at the pano that just got sent to me. You can see the cuspid there, right there. And then this is the final pano at the end with the cuspid in place, not in the transposed position. So pretty interesting what it is that we can do with some PSL, TADs, some micro-osteoperforations, and maybe another way of saying it is being crazy. I don't know. I show other people that case, and they just look at me and they go, "You're nuts. That just doesn't make any sense. Why would you do that?" And I think part of the reason I did is because I finished so many cases where that canine didn't end up in the right place, and their smile just never quite looks right. It doesn't matter how I contour or shape those teeth; the size proportionality just never gives it the look that I'm going for. And of course, they don't get the same kind of function with the cuspid the way that it's designed. So here's another reactive case. So this was an Incognito case. Patient presented. She has a little bit of a full profile, but not full enough to really want to take out teeth, but so much crowding that I was almost forced. I didn't really have any other choice. And she wouldn't do it with traditional braces or Invisalign. She said she was going to do it with Incognito. So here I got to do lingual braces. I've got major crowding. I've got anterior crossbites, and I got a profile that really isn't going to help by extracting teeth. And so I'm challenged. And so this is another one of these cases that's a little bit on the difficult side. So this is a photo showing, it's June 2013, and we've already done one perforation, and the second one in September is basically what's going to happen here. And so you can see the spaces are not completely closed. We started in October of 2010, and we're now in June of 2013, and we still have extraction spaces not completely closed. So we did two perforations, two sets of perforations. And here's a progress in March of 2014. We're using labiolingual mechanics to help close the spaces, power chains on the lingual and Naitai springs on the labial. Here's a progress of May of 2014. As we're retracting the lower teeth and getting spaces closed, we started increasing our overjet and getting our class 2 relationship, so we had to work on that in addition to getting the spaces closed. And so here's October 2014 with majority of the spaces closed, and then here's November 2014 with all the spaces closed, class 1 molar cuspid relationship, and hopefully not too much of a ruined profile, but a little bit flatter than what I would have liked, but I don't think that I had a choice based on the way that she presented initially. And so this is a reactive case with using micro-osteoperforations with Incognito. And then this is a proactive clinical case with MOPs. We decided to do a non-surgical treatment plan with micro-osteoperforations and Incognito. And she did Incognito on the upper arch, and she did clear braces on the lower arch. And so we had originally estimated about 24 to 30 months. We started in February of 2013, and this is what her pano looks like. She had some impacted molars that we had to remove, and she had a root canal on upper left 1. So this is her initial pano on February 2013. This is her Ceph. You can see a skeletal open bite, and this is what she looked like in July of 2014 with 17 months of treatment with 3 micro-osteoperforations. And we did these perforations literally everywhere. You know, second molar to second molar, and so you can see, you know, how that turned out. I think it turned out pretty nice, and then it was stable. We look at that cephalometrically. The bite is closed, and then we look at her a year later in 2015, and the bite is staying closed, and everything is looking pretty good. I tried to get her to do some cosmetics on her upper centrals. I wanted her to do some veneers or something. I didn't like the way that they looked, and eventually I think she had it done. She just never came back to show me the pictures or to have pictures taken. So here's an additional proactive case with MOPs. This is one of the easier ones. This case was initially started in November 2014. We originally estimated 12 to 18 months. We did 2 MOPs, and we finished in 9 months, and that was proactively. And so it turned out really nice with only 2 micro-osteoperforation treatments. So another scenario, this is a little bit more recent. This is something I did proactively on a patient. She came in with a deep bite, and she said, I want to do Invisalign. And I said, oh, perfect, my favorite. I love deep bites with Invisalign. Just kidding. And so I decided, well, if I really want this to be reliable, why don't I throw in some micro-osteoperforations in there? We're going to use our G5 bite ramps, and we're going to, you know, extrude the posterior bicuspids all at Nick Azizi with some really cool horizontal beveled attachments, and you know, I'm going to try to stack as many things as I can in favor to correct this beautiful lady's, you know, deep bite. And so here's one micro-osteoperforation. I literally got the picture the same day, so you can actually see the holes still slightly oozing a little bit. And one of the things that you'll notice is that I don't have 3 holes everywhere, like the way I talked about before. And part of the reason why is because as I started to do more and more holes, I realized that I actually can get away with doing less and less holes. So I'm in many situations, on the first micro-osteoperforation, I might do 2 holes and then 2 holes, and then on the second one, maybe I'll do 1 hole. Or maybe like in this situation, I'm just doing 1 hole in certain areas. And so I'm finding that I don't actually have to do a ton of holes to create the same result. And so this treatment micro-osteoperforation was done on September 30th. And she called me up and she said, Doctor, I'm allergic to this. Take a look at what's happening to my lips. And I said, there's no way that you can be allergic to, you know, to micro-osteoperforation. So I look at her pictures, and her lips are so small. And I look at her lips, and I said, this must be bullshit. So I called her out on it, and she just said, seriously, she just said, no, these are my lips. This is today. And so I started freaking out. I went over to meet her, and I took these pictures, and they weren't actually her lips. They're actually wax lips. But it was pretty funny that she did that, and she got me and my team a little concerned for about a half a second. But yeah, there definitely is no allergic reaction to MOPs. So here's MOP number 2, and I purposely made sure to show you the holes here again. And you can see that I'm not doing any holes where there are frenum attachments or right in the middle. I'm a little bit cautious of that. And so, and then there's no MOPs on the palate. They're all on the facial. So here's January 2016. She's already gotten a pretty nice deep bite correction. And here's our progress case refinement in April of 2016. I mean, she's almost resolved. We're going to try to do a little bit more deep bite correction and see if we can procline those upper teeth just a tiny bit and see if we can get the posteriors to seat. But I mean, pretty nice result in a fairly short period of time. So some other cases, I was talking about palatal micro-osteoperforations around impacted cuspids. And so this was the example from Dr. Gwynn's case, where she estimated it, without MOPs would be 12 months, and actually it ended up taking 6 months with the MOPs. And you can see all the little yellow dots are where all the places where she placed the perforations. So basically, softening up the bone, increasing the, the inflammatory responses, the, increased cytokine response, and allows the body to then, resorb and oppose faster. And here's that other case that I was telling you about from Dr. Gwynn, where she intruded the upper anterior teeth and got rid of the gingival display, and that was literally 1 month progress with MOPs. Of course, there's pretty efficient mechanics there too, but it's pretty significant. And usually that would take several months, 6 to 8 months for that to happen. So, marketing. How do we market Accelerated Orthodontics to help grow our practice with micro-osteoperforations? So advantages to finishing treatment early. Let's see, what are those? When will my treatment be completed? Isn't that the question that every patient asks every day, every appointment that they come in, except for maybe the first one or two? And so now you actually have an answer. You know, when they say, when will my treatment be completed? Instead of going, well, you know, everybody responds different, and, you know, older people and younger people, and you get into that whole story, and, oh, make sure you're not doing the NSAIDs, and you get through all that. What is your answer? It's a best guess estimate is what it is. And I do the same thing every single day. It's my best guess based on what I think I can accomplish in the time frame that I have available and the compliance or willingness of the patient to get that accomplished. So now I can tell them, I believe that if we incorporate a biologic stimuli, a way of creating inflammation locally, that we can actually accelerate your treatment. So how will my patients pay for treatment if I finish them early? That's a very common question. In my contract, I have a paragraph there that says that if patients complete treatment before the estimated treatment time, that they are going to have to pay their complete balance off. And so someone recently asked me actually for a copy of that. I need to send that over to them. But basically, it's the same verbiage that we've always had in our contracts, which is if someone gets their completion earlier, if we estimated 24 months and someone finishes at 22, we don't give them a discount. And the reason why is because they're paying for a treatment result. If they got done a little bit faster, then they should be happy, and you should be happy that you were able to accomplish it faster. But patients associate time with money. And so they will associate the fee. And so if you get done sooner, then they're going to ask, well, if I get done sooner, then can't you charge me less money because you didn't have to do as much work? And the answer is no. I still charge you the same amount of money because I'm still accomplishing a result. Whether I accomplish that result faster for you or not, I'm still accomplishing the result. And I think that's really what they're paying for. And so I think if we gear the conversation towards the result and make it clear to them that their balance has to be, you know, paid by the time their treatment is completed, then it covers that concept. Accelerated Orthodontics is an upgraded service, and I do believe it warrants a higher fee. So I think that there should be a premium. In other words, you should charge for your acceleration. So we typically are going to charge per treatment, or we might charge for the whole thing. So in the reactive scenario, we might charge for one propel treatment or one micro-osteoperforation. Whereas in the proactive cases, we'll be talking about 2 treatments or potentially 3, you know, treatments in their case. So if you finish early, then you get to celebrate and the patient gets to pay early. If you talk about Accelerated Orthodontics as an upgraded service that allows them to accomplish their treatment result faster, then many times patient will see it as a benefit and they're willing to pay that higher fee, but it has to be set up at the beginning. Even if the patient doesn't decide that that's what they want at the beginning, if you set it up at the beginning and then they decide later, then you're going to always be on the right side of the fence. And the reason I say that is because I have found in my practice the majority of my patients that accept MOPs are usually going to be the patients that are in a reactive situation. They want to get their treatment done faster. They're already frustrated. They want to be done. They're asking me, when is my treatment going to be completed? I throw out the, the MOPs, and they're going, this is great. How much does it cost? $250? Done. Let's do it. Let's move forward. I want these things off. And so majority of the time, the patients that are going to be the highest level of acceptance are going to be the patients that are already in treatment. So if you've planted those seeds at the beginning and throughout, then by the time they say that they're ready, then you're in a good place. If you don't already have that in your contract or you don't already have that as part of your arrangement, then when you then incorporate acceleration, then you're going to have that conversation about that they have to complete their payments by the time their treatment is completed. And typically that will raise their monthly payments. So a lot of orthodontists tell me, oh, well, I only see my patients once a month and they pay me once a month and there's no way that they're going to pay me any different and that's the only way I can treat my patients. And I think that's right for you and your practice and your situation for those patients. I'm not going to tell you to change it. But if you ask the patient or give them an option, would you like to get done faster? Would you like to complete your treatment before your estimated treatment time? And you tell them what the new scenario is going to be going forward, I think you'll be happily surprised at what their response is. And it's usually not the response that you think. It's the response that I'm talking about. That they're like, yeah, I want to pay a little extra to get this thing done faster. If you start talking about $5,000 extra, you can do Wilcodonics or something surgery. Nobody wants to pay that. Nobody wants to go through that. You talk about an extra $250, you can get your treatment done faster. You can shave off 6 months or 3 months, depending on how many times you do the MOPs. Well, now it's a reasonable proposition that has no negative side effects, and patients are just eating it up. So is it going to take more doctor chair time? And the answer is, overall, no. It's going to reduce your overall chair time. But to do the actual micro-osteoperforation procedures, it is going to require a little bit more chair time by the doctor to sit there and actually do the procedure. But if it overall chops off a bunch of appointments, 5, 6 appointments, then it's going to pay for itself, and it's going to still be very efficient. So I apologize if this does create more capacity in your office. I think that you'll find if you can finish your patients 40 to 50% faster, you're actually going to have more room in your existing schedule, and you'll be forced to either start more cases or take more vacation. So I apologize if that's what ends up happening. But your capacity will grow if you utilize MOPs, if you can schedule and you can collect properly. If you don't have the ability to schedule and collect properly, then you're going to find some of these cases are going to get a little out of control real quickly. In other words, the cases are going to get finished, you won't have collected the money, and you don't have a system or a process in place to collect the money, and then the patients will get their retainers, and they'll never really pay their balance. Or, if you're with OrthoFi, then I guess that issue doesn't matter, and you can spread it out for as long as you possibly want, and you'll only have a 3 or 4% default rate. So it depends on how you really want to look at it. A practice and doctor differentiator. I believe that if you're incorporating accelerated orthodontics, it will set you apart from other orthodontists, but I don't believe that that window is going to be as big as it was with Invisalign. I think that Invisalign window ended up being like a 7-year window. I think in this situation it's going to be 2 to 3 years. A lot of orthodontists are going to get on board, and then before you know it, the GPs will probably get on board. So will this attract new patients looking for faster treatment? It will, if you can confidently tell them that you will complete their treatment faster. What typically happens with us orthodontists is that we typically are so focused on the perfect result, we still end up taking a long time just because we're trying to be more and more detailed. So I've had several cases that I told them that we'd get done faster, and in reality we didn't get done faster, we just got done on time, but the treatment result was dramatically better. So depending on how you want to look at it, you can speed treatment up, or you can just get really reliable and credible results in the treatment time that you originally estimated versus going over treatment, which we all know can be costly and can be kind of a practice killer. Patients all start walking out the office and telling everybody that you never finish on time. That doesn't help anybody. So will this set me apart from other GPs and other orthodontists? I believe that it will. I think that you should be utilizing technology to set yourself apart from GPs. If GPs are offering X and you're offering X, Y, and Z, then you become the specialist. If you're just offering the same thing that they're offering, then what really in the patient's mind differentiates you as a specialist? Did Invisalign differentiate you? What does differentiate you? And if it does, then ride on it. And if you need something new, start to incorporate micro-osteoperforations. You're going to reduce overall treatment time by 40 to 50%. It does increase confidence in using Invisalign because you're going with a 7-day interval, and you're seeing a lot less tracking issues, and you're also seeing a lot less case refinements and mid-course corrections. And so that in and of itself is probably worth more than the driver. Micro-osteoperforations, how do I charge for them? I charge $250 per treatment on a proactive or on a reactive. Now on a reactive, sometimes we'll try to give them a whole fee, like maybe $800 or $1,200, depending on if we're going to do 2, 3, or 4. And I'll usually just price it for them and just say, oh, full treatment, unlimited number of MOPs. Other people I've also heard charge between $300 to $800 for 2 MOPs. When you're only paying maybe $110 to $125 a driver, you're making a little bit of money on the driver, but you're really making the money on reducing your overall treatment time and getting the case finished on time, or just getting the case finished the way that you wanted. And so I think it's an investment in cellular biology. In the past, we've been very focused on mechanics, biomechanics. How do we create the most efficient wire? How do we create the most efficient bracket with the least amount of friction? And so we have all kinds of really cool tools out there to allow that to happen. But what tool do we really have to affect the patient's bone biology, and I believe this is the tool. So tips are valued at 110 to 150 based on how much you buy. You can apply these MOPs between 12 and 16 weeks. You can do them sooner, but we're not necessarily seeing that you're getting a greater effect. I have found that when I do them on a reactive patient, I'll try to do a little bit sooner because I'm really trying to get the patient completed. I don't have another 12 weeks and then another 12 weeks. I need to get them done in the next, in the next 12 weeks. So sometimes I did show that I'll do it a little sooner, more on a 10-week basis. But build your web presence with a doctor locator. So, there is a doctor locator. Once you make your first purchase, you'll be added to the doctor locator. Obviously, the people that are doing more are going to rank higher and those types of things, very similar to the way Invisalign has it. If you're doing any optimization, these would be some like SEO keywords that you should start optimizing for on your websites or add them to your meta tags. These are some brochures that Propel has created for various doctors or can help you with creating some marketing materials for your practice. There's some various templated letters that you can send out to general practitioners or to your existing patient base, informing them about Propel and what it is that you can do with Propel and accelerated orthodontic treatment. And maybe there's like a letter that you send out to existing patients that maybe you give them a gift certificate for $250 off, which basically gives them one free Propel. And then you can start, finishing your cases faster or even just finishing your cases. Display brochures of your services. So these are other examples of Propel brochures that are showing before and after cases, showing how the malocclusion and the bite ties into the overall general health of the person. And then these are some other, brochures with before and afters. There's the, selfie, promo, picture perfect selfie as quickly as possible. And then there's the other brochure that just shows you the two different drivers. So there's some brochures if you want them. Once you get started, the reps can come into your office and set you up with little brochures and posters and things like that. These are some home pages that were developed, that have Propel on them. Mine is on the upper left side, and you can see some other people's where they've added, Propel information either onto their blog or onto their website. And here are some more examples of doctors that are either added them to their blog or they've actually added a website page. And so that's pretty much all I have on using micro-osteoperforations to grow your practice. This was the part 2, so hopefully I did some summary and I introduced some new points for you guys. The future has to do with other tools and other things that we can use to accelerate treatment, and this topic was really just focused on micro-osteoperforations. So if you do have any questions, we do have a little bit of time for some question and answer. There is a little question board there. If you want to shoot out some questions, I'll be happy to answer them and explain whatever it is that I didn't clarify for you. And so if you have any questions, just go ahead and shoot them out there on the little screen. So someone wrote here that the compound topical composition slide is 10% prilocaine, 10% lidocaine, and 4% tetracaine, and that's one formulation, and the other formulation is lidocaine at 12.5%, tetracaine at 12.5%, and prilocaine at 3%, and phenylephrine at 3%. So there are some different, different compounded topicals that are very profound that you can put together, and just depending on what you feel comfortable with. The one that I've used a couple different styles, but usually it's going to be the tetracaine and the prilocaine that make it much more profound. So one question here, it says, have you used Propel to reduce gummy smiles? Nice result in the one case you showed. I have used Propel to reduce gummy smiles. I didn't get quite the same reduction in treatment time the way that Dr. Gwynn did. Typically I'm using 2 TADs either between the upper 2s and 3s or between the upper 1s and 2s, and then I'm using night high springs to pull the teeth up. We have reduced gummy smiles with Propel. We've gotten people set up for surgery with Propel to get them to the surgical date faster. We've done all kinds of things. I just showed you just like a handful of some cases that I thought were kind of a little bit outside the box. But yes, you can. Any other questions? Please feel free to ask. So ultimately, Accelerated orthodontics gives us the ability to not only achieve a result faster, but gives us the ability to achieve an incredible result that we may not have been able to achieve in the past. I don't believe that that scenario where I moved that transposed cuspid, that if I wasn't softening the bone, that I wouldn't have gotten as much, root torque, and I probably would have gotten more root resorption along the way. It says here, the next question is, do you propel the entire upper arch for reduction in gummy smile? And the answer in that situation is no. I don't usually propel the posterior teeth on the top if I'm trying to just intrude the anteriors, and that's where my differential anchorage could come into play. So I'll soften up the bone in the anterior, create the inflammation, so I can get the intrusion in the anterior, and I don't really do any perforations in the posterior where actually I don't want those teeth to move at all, because I'm not really reducing the gummy smile by intruding the posterior teeth. I'm really doing it by intruding the anterior teeth. So I hope that answered that question. If there's any other questions, please just go ahead and write them out on the question. And if you don't know where it is, it's that little window that controls the screen. There's something there that says questions, and you can write in questions. I'll be more than happy to answer them. My recommendation is purchase the initial kit with the driver and some tips, or the automatic driver, and start using it. It's a very inexpensive start. It's nothing like some of the other devices that are out there that are a lot more expensive, and try utilizing it. If you try it and you really find that you're having difficulties with it, send me an email, reach out to one of the other KOLs, Dr. Shipley, Dr. Nicozizi, Dr. Pobans. We're all here to help you be successful with integrating this procedure into your clinical daily practice. I always seem to get this question, can you move ankylosed teeth? And I think that's a very good question, and the answer is no. And the reason I know that is because I've tried. I had a few teeth that just didn't move, and I just kept perforating, doing MOPs. I did 2 or 3 times with it, and the teeth just still didn't move. So as of yet, I don't think that you can apply micro-osteoperforations to ankylosed teeth. I think once the tooth has fused to the bone, and of course you don't really know that until you apply a force on the tooth and the tooth just doesn't move, or the teeth all around start to intrude and that tooth just doesn't move. And so the answer is no, you can't use micro-osteoperforations to move ankylosed teeth. But very good question. In a first premolar extraction case, do you perforate only in the exosites or the whole segment you want to retract or protract? Typically, I'm going to, in an extraction case, I'm going to probably perforate all the teeth that I want to move. So for example, if I'm in a maximum anchorage case and I want to just retract the anterior teeth, I'm only going to perforate literally like probably distal of the second bicuspid to distal of the second bicuspid. I probably won't perforate between the the molars. If I don't want maximum anchorage and I want some like reciprocal anchorage and I want the posterior teeth to come forward, then probably what I'll do is I'll just perforate in the posterior. So I'll just perforate from like 3 to 7, distal of the cuspid to distal of the second molar, and I won't perforate in the anterior at all. So I use my perforations as a way to create my my anchorage. And so if I don't want any anchorage at all, then yeah, maybe I'll just perforate everywhere and just let kind of everything. Let the front go back, let the back go forward. Let's just get it all going. Sometimes in a scenario where I'm setting up for surgery and all I want to do is get those spaces closed and upright the anterior teeth, I might do that. Just perforate everywhere and just close the spaces everywhere as fast as I possibly can. So it just kind of depends on what I'm trying to do with an extraction case, whether I want to use anchorage or I don't want to use anchorage. That's typically how I'll use the propel and where I'll place the propel. Again, I stay away from the frenum attachments. And another thing that I've done too is I've actually had some patients that had some periodontal defects that we actually did some periodontal surgery on to try to build those defects. And I decided to do MOPs into those areas. And the part of the reason why is because radiographically I would see them as being almost like not dense, almost like radiolucent. And it just looks like there's not enough bone there. So I just micro osteoperforate into that area, and I just find that the bone starts to get a little bit more dense and starts to get a little bit harder, and then as I see on further x-rays, the bone is a little bit more dense. And so I actually started using it in a couple areas where I had some periodontal concerns, and I found that it didn't create any negative effect. I haven't done any histological studies to show what the actual effect was, but my anecdotal viewpoint on it is that it actually helped to solidify the bone in that area faster. So you guys have got some great questions. Please don't be shy. Ask whatever questions you might have. And there's my email address on the last slide. If you don't feel comfortable asking a question through the webinar, then just go ahead and shoot me an email. And those are my two websites. I have a website for LA, one for Beverly Hills. I'm really excited for this opportunity to share all this information with you guys. I will be doing and having more information on Accelerated Orthodontics in the future. And like I said, I am writing an article right now that should be published in around September. And so I'm looking forward to sharing some even more outside-the-box cases with all of you. And so thank you very much for your time. If there's no further questions, I'm gonna end the seminar and stop the recording. And I really, really appreciate all the questions and the feedback along the way. Thank you.